views and opinions expressed in this program are those of the participants and do not necessarily reflect the views of BronxNet or the program underwriters.
Welcome to Public Health America, a 30-minute program on BronxNet where we talk with national experts to promote health and social justice. I'm your host, Dr. William Latimer. We begin by focusing on a current health topic from the COVID pandemic to cardiovascular disease. Our goal is to provide you with not only the best science, but practical tips to live a healthier life. On Public Health America, we also celebrate what studies have long documented, namely the unparalleled value of a college education by setting the stage to pursue a career of your choice, increase lifetime earnings and opportunity, and champion the ability to engage in civil debate. But for many, finding a path to college is neither clear nor certain. What if you're a high school student with supportive parents, but feel daunted by the prospect of being the first in your family to attend college? What if you're a single mother or father and want to attend college, but have no childcare? On Public Health America, our expert will also talk about decisions they made and support they received that helped them beat the odds. By sharing one or two life lessons, their stories may provide you with the inspiration and method to realize your dreams. This is Public Health America. Welcome to Public Health America. I'm your host, Dr. William Latimer. It is my pleasure to welcome as our guest today, Dr. Kelli Allen, Research Professor of Medicine at the University of North Carolina at Chapel Hill, and Associate Director of the Center of Innovation to Accelerate Discovery and Practice Transformation at the Department of Veterans Affairs Healthcare System in Durham, North Carolina. Kelli, welcome to our program.
Thanks. Good to be with you.
Thank you. So, I know you've been doing some really important work on the intersection between chronic pain and non-pharmacological treatments for chronic pain. Certainly one can open up any newspaper and see sort of the scourge of opioid dependence and abuse, and some of that is due to chronic pain. But why don't you set the table for us?
Sure. Yes, exactly. As you said, there has been obviously a lot of attention to opioid misuse and abuse over the past several years. That's a multifactorial problem, but certainly at the heart of a lot of it is the increasing incidence of chronic pain, things like osteoarthritis and back pain, but other things as well. And really our, probably lack of attention to non-pharmacological treatments over the years have been one contributor. There's many reasons for it. But simply put, chronic pain is a very difficult, it's difficult to treat, difficult to deal with for people who experience it with it. We don't have a lot of spectacular tools, single tools to treat it in terms of medicines. Really, they're limited. We have a lot of tools that do help. Exercise, different behavioral therapies are helpful, but we've not really used those as well as we could. And I think part of it is because they are challenging, they're difficult, but there is evidence to show that they are effective. And so I think that's sort of at the root of the problem, is that we as a kind of medical system, healthcare systems in our country have emphasized pharmacological treatments, and we've not done a really good job of integrating the non-pharmacological as well as we could.
So give us a sense of prevalence, like how common is chronic pain? Does it vary by age group? What are the kinds of disorders or diseases or conditions that seem to be associated with chronic pain? Just how big is the problem?
Mm-hmm. Yeah, so I will pull a couple of statistics out of my back pocket. The area that I work in most is osteoarthritis. It is one of the probably top two common causes of chronic pain, at least in adults and older adults, the other one being low back pain. Osteoarthritis of the knee, the lifetime prevalence is about 1 in 4. I think that's right. No, it's actually almost 50%. So very high prevalence of osteoarthritis in the knee. Hip is also common. So it's pretty likely for most of us, if we live to an old enough age, we're going to be experiencing some kind of pain due to arthritis or low back pain. Now, if you look at the prevalence of chronic conditions as a whole, considering other things like diabetes, hypertension, heart disease, they are more common than things like osteoarthritis and low back pain. But if you look in the US at the most common causes of disability, that is where you really start to see the impact. Arthritis and other musculoskeletal conditions, including back pain, are number one. So that is the biggest cause of functional limitations and disability in our country. It's not heart disease, it's not diabetes, it's musculoskeletal conditions.
And in the case of lower back pain, how much, I mean, I've interviewed a lot of people that, you know, and it just seems like there was a period where everybody I interviewed was focusing on rates of obesity being out of control in the US among just about all age groups. If this is the wrong question, you can redirect me right away, but to what extent is being overweight related to lower back pain?
Yeah, it's definitely a strong risk factor for low back pain and osteoarthritis. For low back pain, there are lots of different causes of low back pain, so it's a little bit of a heterogeneous or mixed groups. There's lots of reasons it can occur, and not all of those reasons are linked to obesity. But we do know that overweight and obesity is still a strong risk factor for low back pain, and then subsequently that reducing weight is helpful for reducing risk of low back pain and reduce the amount of pain in people who do have back pain.
So you sort of alluded to this. Give me a sense of, you know, rates of low back pain and arthritis are high. What is the chance if I go in to my primary care doc or internal medicine that I'm going to get medication at the outset as opposed to some kind of discussion of options? Is that a fair question?
Yeah, that's a fair question. And I'll first start by saying that there's a lot of variability in terms of what healthcare providers do. And I think that is changing a little bit over time as we start to emphasize these more non-pharmacological care models or holistic care models. If you look at research in this area, it would suggest that you're fairly likely to be prescribed medications or imaging like MRIs for back pain, which typically is not something that's indicated, at least as a first strategy for diagnosis. So there has been this sort of, we like to talk about it as sort of the medical model, where those types of things that we're talking about, imaging and medications, are sort of first line. I don't know if we have like one number that would answer your question specifically about like what's the likelihood that would happen. I think there's just, again, a lot of variability in providers and health systems, but on the whole, we do know that number is probably not optimal. We have some room to grow, room to get better, because it should be 100% of the time that for any of these conditions like arthritis and low back pain, that the provider is discussing options in terms of things like physical therapy, exercise, weight loss. Now, that's not to say that medication would not be indicated if you go to the doctor, right? So if you go and you have some acute back pain, it would not necessarily be bad for that provider to say, oh, well, you might want to try these non-steroidal anti-inflammatories for a couple of weeks and see how you do with that. That's okay. That can be part of the treatment care package. But the problem we've had is that we've used those tools in sort of isolation of the other things.
And again, we're talking about a chronic condition or a condition that is potentially chronic, particularly as we age. Is pharmacological, and I'm asking this question truly naively, is pharmacological treatment viable long-term?
That's a good question, and it depends on the conditions. They're not all like arthritis and low back pain. Those might be two different scenarios. So for arthritis, it's fine. Many people do use medications along with other things to manage their pain over time. And in terms of whether it's viable, I mean, it is. I think that there are, for example, risks of non-steroidal anti-inflammatories over time, or things like gastrointestinal bleeding and So there are risks, I think, on low dose medications. In combination with other therapies, it can be, not great, but part of the strategy to continue on medications for an extended period of time. I don't think anybody wants to do that. That's not the optimal strategy. But depending on the dose and type of the medication, it can be okay. But again, just emphasizing that can't be the only part of the treatment plan, because medications alone are not going to completely manage pain for people, and it's not going to help them improve their function.
So how do we move the needle so that more non-pharmacological treatment options for pain just become a part of the lexicon of docs and physician assistants and nurses that are interacting with ostensibly hundreds of thousands, if not millions of people that in the United States that have pain? Is this a training issue? Do we need to change the way health professionals are trained? Is it a policy issue? Is it an insurance issue? Like, how do we move the needle?
Yeah, I think all of those things, and maybe other things as well. I don't think it's an easy solution. I do think that training is part of it. I think there's things are going in a better direction in terms of making sure that there is that kind of training in medical schools. So it is that. I think also health systems, so in research, there are some good care models that have an evidence base for, comprehensive, good non-pharmacological plus pharmacological care models for back pain and osteoarthritis, but we haven't gotten as far as implementing them in healthcare systems. So I think there are some systems things that need to happen, and I think there are some insurance things that need to happen. There are not good ways for patients often to be reimbursed for things like psychotherapies, physical activity, and those sorts of things. So I think there are reimbursement issues. And then I think also on the patient side, on our side, any of us who come and are coming to healthcare providers with chronic pain, is just being willing to do the things that are difficult, right? So sometimes losing weight is not easy. Changing your activity patterns is not easy, but and we need support for that. People often need support for that, but I think that's maybe one other factor that we need to make some headway on.
Very good. So we have about a minute left. What is the area of research or clinical practice that you're working on these days that you think has the best chance to move the needle forward in a positive way with respect to non-pharmacological treatments for pain?
Yeah, that's a good question. And I think some of my favorite projects that I'm working on now are really focused on what we consider implementation science or quality improvement, and really is taking those interventions that we've studied in the research context and figuring out how to move them into clinical practice. How do we get them to function and operate in primary care or in a health system holistically? So I think those are the things that we're seeing more and more of and really have promise to move the needle. There's still a need for better therapies for a lot of these conditions, but I think we also need to be better about using the tools we have. Makes sense.
We're going to take a quick break. When we return, Dr. Kelli Allen will tell us a little bit about her own story through academia and as an undergraduate, and life story and life lessons that enabled her to chart a professional course forward. We'll be right back on Public Health America. Welcome back to Public Health America. I'm your host, Dr. William Latimer. Here with me today is Dr. Kelli Allen, Research Professor of Medicine at the University of North Carolina at Chapel Hill and Associate Director of the Center of Innovation to Accelerate Discovery and Practice Transformation at the Department of Veterans Affairs Healthcare System in Durham, North Carolina. She is also the Editor-in-Chief of Arthritis Care and Research. So Kelli, we were just chatting about non-pharmacological treatment of pain. What I always start this segment with is just asking each guest, where were you born, and tell us a little bit about your formative experiences.
Sure. So I was born, technically in Pittsburgh, Pennsylvania. That was the hospital, but I lived in a very small town called California, Pennsylvania, which is about halfway between Pittsburgh and Morgantown, West Virginia. So a fairly rural, small town, which was wonderful place to grow up in many, many ways. It was a very close community. I had a lot of family around, and that was great. But I would say one thing about that area is that opportunities were kind of limited in terms of academics and those sorts of things. And I went to a good supportive elementary through high school. But I think for me, sort of leaving the nest after that what was a good thing. I went and did my undergraduate degree at Penn State, which was just a few hours away from home for me, and was an opportunity for me to kind of spread my wings a little bit and see some new things, experience, learn from experiences of different people, and just get a bigger view of the world than I may have in a small town. So that was an important formative part of my experience.
When you went to Penn State, were you a first-generation college student at that time, or had your parents gone to college?
I was a second. Yeah, my parents had gone to college. I was a second generation. I would say that's right. My grandparents were also in sort of a small town adjacent to where I was, and worked in steel mill and worked in had some businesses that they ran, and so I learned a ton from them in terms of work ethic, actually. And then my dad was the only one of his siblings to go to college. So anyway, I got to see lots of different experiences and how people kind of did life with different paths as far as how much education.
And going from slightly rural, we'll call it, to urban at Penn State, were there any challenges associated with that transition, or was it just fun and exciting?
Yeah, well, college is always fun and exciting, right? It was actually for me. It was it was good. So the biggest difference for me, so State College is not super urban, but it was much bigger, just many more people, and so there were challenges just in terms of figuring out my way, going from one person in a small town where I knew lots of people to going to this very, very large university, where I really, I knew a couple people going in, but not really many. I just took that step and, went and had a very different experience. And so, yeah, I mean, just kind of figuring out how you fit into the bigger piece of this big world out there, I think was both fun and exciting, as well as sort of challenging, but challenging in a good way.
Sure. For undergraduate experience, we've heard a number of stories, and they seem to, this is an oversimplification, but they fall into kind of two buckets. One where undergrad really was 90% exploration and 10% kind of figuring out what the future may hold. And then there was another group that sort of had a sense early on what they wanted to do career-wise, at least initially. What was your undergraduate experience like in that respect?
Yeah, that's a great question. I went to Penn State because I thought I wanted to be an architectural engineer, and Penn State is one of only a handful of places in the country that has that. Within about 3 months or so, I was like, yeah, that's not me. I was taking physics. I was like, I can't really do physics that well. Like, it's okay, but I don't love it. And so that was one of the great experiences of college for me, is realizing who I was not and who I was just in terms of what my interests and aptitudes were. So I was, looking back now, I can see some things that I liked to do through my kind of high school years that I'm now doing. And part of that is writing and science, but I don't think I recognized it then. So I was not one of those people who's like, oh, I want to be a doctor, I want to be this or that. Again, I can see those patterns there, but for me, it took going to school, getting in some different classes that I just got to learn things I'd never heard of before, and just having some new experiences, just kind of internships and just different, more practical aspects of courses to just kind of find something I could latch onto that I thought was really exciting.
Right. So that's, I think that's such an important anecdote in the sense of one thing college can do is to teach you what you don't want to do.
Mm-hmm.
And I would suggest that that's unbelievably valuable information.
Mm-hmm. Mm-hmm.
And perhaps doesn't get as much billing as it ought to. Were there other kinds of standout? So you also mentioned experiential learning, that doing
Yes.
internships and doing stuff in the community was another sort of way to figure out that journey and what next steps might hold. Were there other sort of elements of your undergraduate experience, either with peers or with mentors, that you sort of look back on as being critical, or something I'm not mentioning?
Mm-hmm. Yeah, I think, part of it was just being in specific classes. I can remember, especially after you get through the first year-ish of those kind of core college classes, just taking some, just the learning part of it and learning about things that are more specific than maybe just general biology. Like I loved my exercise physiology class, and just some other things that are, again, things that you maybe never heard of in high school that are more specific and that are kind of taking you down a more specific trajectory. So, that was really important. And and I think too, just back to what I was mentioning before about internships, some of my classes were, I was an exercise physiology major. And so I could, we did classes where we were working with people who had different health conditions and helping them to adapt exercise programs to meet their needs. And, those are just some examples of things that made me, allowed me to get a taste of, do I like this? And then went on to do my master's degree also in kind of health and exercise science. And again, more of those experiences of working with people and like cardiac rehab and similar programs. So I think for anybody that's in school, thinking about college, it's just any opportunities to practically try things. Because I don't know, I've seen that a lot, that it is helpful to be able to see what you like academically, like what gets you interested in. But there's a difference, I think, between what that is and then what you actually like to do, because you can do different things with the same kind of knowledge, if that makes sense, right? You can be trained in, I don't know, some kind of science, but you can be doing very different practical things with it.
Sure. And, not to state the obvious, but your undergrad and master's in exercise science and physiology clearly informed your work as an MD, right? I mean, meaning that you're looking at, ways to deal with chronic pain without medicine or an over dependence on medicine. And so it would seem as though your undergrad and master's really played into that area of research.
Yeah, for sure. I actually have a PhD rather than MD, but what you're saying is exactly true. I think because it sort of really took me down this path of, I work in health services research, so I do work in healthcare systems. But a lot of what I do in that research is trying to unfold these types of things with, physical activity and rehabilitation in the health system context.
Got it. Thank you. So where'd you go after undergrad? Did you work for a while? Did you go straight to the PhD? What was the next step?
So I went and did a master's degree at Wake Forest University in health and sports science, it was called then. And that's where I really got introduced to research. Did a little bit of that in undergraduate, but at Wake Forest, I got chance to do more sort of clinical exercise physiology stuff, but also I had to do a master's thesis. And that's when I kind of learned, like, oh, I kind of like this. I really like learning, like trying to discover new things and new things that really help people. So that was definitely formative. And then I worked for a few years after that, and in particular before doing a PhD. And then that is where I got most interested in chronic pain. I worked on as an exercise physiologist on some research studies that were focused on helping people with chronic pain, to use exercise and other behavioral strategies to help manage that pain. And so that's kind of what set me on this specific trajectory that I've been on for a while now.
Sure. And then, so you worked for a few years, you got a lot more practical experience, focusing on exercise physiology. What was the next step for the doctorate?
Yeah, so I went back to Penn State and did a doctorate in what was called biobehavioral health, and spent a few years there learning more. And the reason I did the PhD, it's definitely not the only path. There are good reasons to do that and less good reasons to do that. And for me, it really was just a step I needed to take because I thought I wanted to kind of lead my own research program. And so that's the training I needed to go through to get that. So I did that and then came back to North Carolina and have been here since, working at the VA. And yeah. That's
great. So we've got about a minute left. Kelli, if you were to give one piece of advice to a high school student in the Bronx or NYC or beyond of what will help them get to college and succeed there, what would that be?
We've already talked a good bit about practical experience, and that would have been maybe my first one. But since we've talked about that, I will say mentors. So if you can find people, teachers, other people who know you and who can impart their practical wisdom to you, help you in different areas. And it's not just one mentor, it needs to be a set of mentors who can just help you based on their experience and just speak into your life in terms of what they see in you, what they think you're good at, and they see you enjoying most. I think that's really critical.
Yeah, I completely agree. And it's advice I often give to new students at all levels, because so many students today that I work with particularly are just so unbelievably busy. I don't remember being that busy, but working one or two jobs. A lot of people that go back to college have families, and so to do all the things that we're suggesting is not always easy. But finding that mentor that isn't just telling you what courses to take, but you're developing, in effect, a lifelong relationship with, is just critically important. I want to thank Dr. Kelli Allen for joining us today and telling us a little bit about her journey and her research. I want to thank our viewers for tuning in. I'm your host, Dr. William Latimer. See you next time here on Public Health America.